Hello, everyone, and thank you for attending today's webinar. My name is Tiara Brooks from SchoolBased Health Alliance, and we would like to thank everyone for attending today's webinar titled Vision Screening 101, Is Vision Screening in Eye Health an Integral Part of Your School Health Program? This webinar will give you a better understanding of childhood vision conditions, types of vision screening for children, valid, reliable, and age-appropriate tools, methods, and resources. We will now review a few housekeeping items. If you are viewing as a group, please go to the chat window in the question box and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance account. Also, just a few reminders. All attendees are in listen-only mode. However, we want to hear your questions. So please remember to enter those questions in the question box. Attendees also will be asked to complete evaluation polls at the end of the webinar. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 3 to 5 business days. Please also visit SchoolBased Health Alliance for additional archived webinars. I would like to introduce our presenters for today's webinar. Our first presenter is Dr. Moore. Dr. Bruce Moore has been the Marcus Professor of Pediatric Studies since joining the faculty of the New England College of Optometry in 1997. Dr. Moore's research focuses on vision screening and examination and vision care of children. He has been a principal investigator at the Boston Clinical Center for the Vision in Preschooler Study, funded by the National Institutes of Health and the National Eye Institute since 2000. He is a fellow of the American Academy of Optometry, a member of the Association for Research in Vision and Ophthalmology, and is the manuscript referee for many academic journals in optometry and ophthalmology. Dr. Moore earned his OD degree from the college in 1975. Our next presenter is Dr. Lyons. Dr. Stacy Lyons is a professor and the chairman of Specialty and Advanced Care Department. She lectures and teaches lab sections in the binocular and optometric analysis pediatric optometry and the principles and practices of optometry science, where she lectures on vision screening and communicating with children. The primary areas of focus for Dr. Lyons' research are in public health, vision, learning, and alternate models for delivering care to children. She is a fellow of the American Academy of Optometry, a member of the American Optometry Association and the American Public Health Association. Dr. Lyons earned her Doctor of Optometry degree for the college in 1988, completed a residency in pediatric optometry at the college in 1989. As an alumna, she is currently delegate to the Alumni Association. Our final presenter will be Rhonda Stram. She is Senior Manager of School-Based Vision Centers, OnSite, a 501c3 nonprofit committed the global vision care crisis worldwide. Rhonda has over 30 years of optical experience, starting as a licensed optician in 1987 and working in optical retail industry with the global optical retailer Luxottica. Currently in her role with OnSite, Rhonda is helping to expand the School-Based Vision Center model, which is started in Cincinnati, Ohio. The OnSite Vision Center of Orler School opened in 2012, and since its opening, the center has helped over 7,000 students to receive comprehensive eye exams, and 70% of those students received high-quality, fashionable eyewear. The OnSite Vision Center at Orler is the first financially sustainable school-based vision center in the United States. Before we have Dr. Moore present, we would like to ask you a couple poll questions. Our first poll question is, what type of provider are you? We would like to give everyone just a few seconds to answer the question. Thank you, everyone. And our poll results are in, and we have 73% that are school nurses. Our next poll question do you currently provide vision screening? We would like to give everyone a few seconds. Thank you, everyone. 94% said yes. I would now like to introduce our first presenter, will be Dr. Moore.
Okay, thank you very much. My name is Bruce Moore, and I'd like to thank everyone for attending this webinar today. And the first thing we're going to talk about is sort of setting the stage, giving everyone an idea about the types of vision problems that we need to be concerned about with children, and give you some background on what those conditions are. So the very first thing in the slide is, why should we care about the vision of children? It's a good question. The first thing that's, I think, important to be clear about is that vision disorders are a highly prevalent condition. They are the fourth most common disability in the United States today for children and for adults. And vision problems are the most prevalent handicapping condition in childhood. A child with a significant vision problem is very often a child that also has an associated learning problem. We know from a variety of research that there is an intimate relationship between vision problems in children and learning problems in those children. So that is a major reason. It's not only a health problem, but it's also an educational problem. Now, furthermore, we know that many of the vision problems that we will be talking about in the next few minutes, we know that early detection and early treatment improve outcome. That's true, obviously, for many conditions, but it is especially true for vision problems that can cause either permanent vision loss or cause problems with a child's ability to learn. And finally, an important consideration is that vision problems in children are almost always occult problems. Occult problems simply mean that child doesn't know they have a problem. All too often the parents don't know the child has a problem. And the only way we're going to know that a child has a problem is if we do effective screening or examination of that child in order to understand if the child does have a problem, and if so, what the problem is, and then getting the child into care. Let's talk a little bit about the epidemiology of vision problems in children. And these are the 5 primary groups of conditions that we need to be concerned about. From the pediatric eye doctor's perspective, amblyopia is the most important problem. And it's the most important problem because many of these other issues are related to that. So we'll talk about amblyopia first. First of all, what's the incidence of amblyopia? Generally, it's considered that about 3% of the population of children, of adults, has amblyopia. In a classroom setting, it means that more or less one child per class on average will be an amblyope. Amblyopia, because it's about 3% and because there are about 4 million births a year in the United States, that means that approximately 125,000 new cases of amblyopia present in this country per year. That's a common problem. And it's not only a common problem, it's a problem that really has great significance in a variety of ways. What is amblyopia? Amblyopia essentially is reduced vision, typically in one eye, occasionally in both eyes, that is not alleviated simply by putting a pair of glasses on. I'm going to hazard a guess that many of the people on this webinar right now have a vision problem. Many of those people, the vision problem is going to be refractive error and specifically myopia, difficulty at distance seeing. You put a pair of glasses on, the vision improves pretty instantly. For some others over the age of 40 or 50, it's presbyopia and need for reading glasses. Same thing, you put a pair of glasses on, problem goes away. In amblyopia, that's not the case. Simply putting the glasses on does not provide an instant fix for the problem. What happens is that because there is poor quality of an image that is projected onto the retina, the back of the eye, that image then goes up to the visual processing areas in the brain. And if one eye has a deficit in terms of a non-focused image falling on the retina, the image that gets projected up to the brain also is not a clear image. It then leads to a cascade of neurobiologic processes that occur that lead to, as we describe it, amblyopia. Amblyopia, for the most part, is reduced vision, but there are some other things beyond the clarity of vision that are associated. I'm not going to go into that. The problem with amblyopia is that there is a critical period of visual development. And what that means is that we need to identify this problem within a period of time and mitigate the problem within a period of time. And if we don't do so, we, over a period of time, lose that potential to improve the child. In the past, it was widely considered that somewhere around 7 years of age was a cutoff. We now recognize that that's not entirely true. So it's a common problem, and it's a problem that also leads to a number of issues. One of the most important issues is that an individual that has vision in only one good eye at an early age turns out, based on a very large study done in the United Kingdom about 10 years ago, to be up to 50 times more likely to lose vision in their remaining good eye through injury or disease or some other issue over that individual's lifetime. And although we can agree that having vision in only one eye may or may not be a big problem, no one's going to argue that having vision in neither eye of an acceptable level is not a major problem. In the context of children, the big concern is the effect upon a child's ability to learn. The pictures underneath in this slide, on the left side, is an image of a child with amblyopia trying to view what goes on in the classroom through that eye. Child's not able to see that. The other eye may have some effect as well, some adverse effect. Picture on the right, of course, is the way it should look. So amblyopia is not only a medical problem, it's also an educational problem. Second condition we'll talk about is strabismus, or crossed eyes. Very often strabismus is associated with amblyopia. Strabismus occurs about 3 or 4 or 5% of the time, depending on the study. About half the time the eyes are crossed, one eye is turned in, as it is in the slide here. About half the time the eye is turned out, and depending on the position and depending on the cause, has a lot to do with the significance. Once again, a child with only one good eye is at much greater risk of losing the remaining good eye at some point in their life. In addition, school setting for children, it's also very much a social issue. A child with a crossed eye is more liable to be bullied or have other issues with other children that may impact this child's psychosocial situation. Refractive error is the most common problem. Again, I mentioned myopia and many of the people in the audience. Same with presbyopia, reading problems. Young kids don't have presbyopia. It's a condition for adults. Most common condition that affects children's vision is farsightedness or hyperopia, where the light coming into the eye comes to a focus behind the eye. The child then needs to exert focusing effort or accommodation to get the image clear, and in doing so may cause a lot of eye strain if both eyes are affected and if, in particular, it's of a moderate to a high degree. This is the most highly associated refractive error with amblyopia. The diagram on the left side on the bottom is a child with a nearsighted eye. Light comes to a focus in front of the eye. We need glasses to move the image to a position on the retina. Astigmatism is when the eye is shaped a little bit more like a football than a baseball, so that the shape of the eye up and down is different than the shape of the eye side to side. The problem here is that if there's enough astigmatism, it can create a problem whereby the child looks at, for example, a letter T. The arm going up and down may be clear, whereas the arm going across is not. So instead of a child recognizing that as a letter T, they may see it as an I or a hyphen. And that can create some very significant reading problems. Anisometropia refers to unequal refractive error, where one eye has a higher refractive error than the other eye, and that is a prime cause of amblyopia. It's most typically associated with hyperopia, farsightedness, and or astigmatism. This is a major concern for pediatric eye doctors. We look for this, and we need to do something about it. Significant refractive error simply means, is it high enough to cause a problem? If it's not high enough to cause a problem, then frankly it's not a problem. Binocular or functional vision anomalies are a very, very diverse group of things and conditions. A child with binocular problem may not be able to use the eyes well and effectively and comfortably as a pair. That can create difficulties in the use of the eyes, and particularly can have an adverse effect upon school performance. If a child is unable to get the eyes to turn in properly to focus at a near object, the child may see double under certain conditions. There are a wide variety of these conditions. They can affect children in different ways, but an eye examination would be required to determine the exact specifics of this. And finally, eye disease. Incidence of eye disease is relatively low in kids, lower than in fact in any other age cohort population. Conditions below, the picture on the left side is a newborn infant with neonatal conjunctivitis, something we never want to see. Obviously, the problem here is that this child was born under difficult circumstances that all of you are very aware of. A lot of eye conditions are as obvious as something like this. No one is not going to look at a child like this and know something is radically wrong. Same thing with the picture on the right side, which is a picture of the back of the eye, of the fundus of the eye. The big, very dark lesion on the eye is a scar from a parasitic condition, toxoplasmosis. Again, if you use an ophthalmoscope, if you look in the back of the eye, nobody's going to miss a condition like that. So both of these are good examples of conditions that are very obvious if you look. Most eye disease is in fact fairly obvious if it's going to affect the vision of a child. A lot of eye disease is simply caused by bad genetics or bad fetal development, and there isn't a whole lot we can do about many of those conditions. No discussion today in medicine is complete without at least mentioning the necessity of us thinking about evidence-based medicine in everything we do, including in the case today of how we go about thinking about and treating pediatric vision problems. Evidence-based medicine has become kind of a buzzword. I think many of us feel a bit oppressed by the concept, but it is a really important issue. It's something that all of our practice in the future is going to be more and more directed on satisfying evidence-based medicine, and our whole practice of healthcare delivery is going to be grotesquely and completely influenced by that. There's good things and there's bad things about that. I'm not going to say much more about it except everything we do needs to at least be considered to be based upon evidence basis. So how do we go about treating these conditions? For example, how do we treat refractive error? Well, the obvious is, particularly with children, is glasses. And eye doctors take care of children, prescribe glasses with frequency. Unfortunately, the problem is kids don't necessarily keep those glasses on. There are, of course, social issues related to that. A lot of children don't like the way they look. They're afraid they're going to be bullied, picked on, all of that sort of thing. Nonetheless, if a child needs glasses, they're going to do that child absolutely no good if the child is not wearing glasses in school. Many of the programs that I'm associated with, we endeavor to keep one pair of glasses in the teacher's possession at school, another pair to be used at home. So we know for at least those hours when the child is sitting in the classroom, that child will benefit visually in the educational framework of the classroom by having those glasses on. So glasses are a critical element, and it's something that really forms almost the basis of a lot of our treatment of pediatric eye conditions. Amblyopia, as I said, is a major concern. The treatment of it is dependent on the cause. There's one additional point I want to make, and that is you think about amblyopia affecting only 3% of the population, 125,000 new cases a year. The sum total is of people in the United States under the age of 45 years of age, more people have significant vision loss as a result of amblyopia than all of the causes of vision loss combined. The issue here is that we can detect amblyopia in the vast majority of children. We can treat it effectively, at least in concept, in many. Glasses are the first line of treatment. If we're not successful in treating this, this becomes permanent vision loss. And it affects more people than all of the causes of vision loss combined. People think about cataracts and glaucoma and macular degeneration. Those are not conditions that affect children. Amblyopia is. Eyeglasses are invariably the first and most important treatment. You've got to keep those glasses on for a period of 3 or 4 months. Child then needs to be reevaluated. And then most of the time, we need to initiate secondary treatment in the form of either putting a patch on the good eye to force the child to use the amblyopic eye, or the use of atropine eye drops that blur the vision up in the good eye, which also forces the child to use the amblyopic eye. Either one of those have been shown to have equal effectiveness by a variety of studies that have been done in the last 20 years, and that forms the most important framework for treatment. Strabismus, the treatment for strabismus begins with treating refractive error and treating amblyopia first. If there is still residual strabismus left, that may be treated in a variety of ways. They may be treated non-surgically by using additional glasses or eye exercises or vision therapy or in some combination. And sometimes we need to resort to surgical intervention to get the eyes cosmetically straight and to get the eyes hopefully working better together as a pair. The difficulty here is that the most important part is treating the underlying condition first, which is invariably a combination of refractive error and amblyopia. The three conditions of strabismus, amblyopia, and refractive error are very intimately related, and invariably in children, treating one means you're treating all three. How do we treat binocular problems? Again, glasses are a critically important component. Vision therapy, eye exercises in a variety of ways are very important. These issues are less apparent than amblyopia, but these issues are more common, and these issues affect many children in the classroom. This is a perfect opportunity of how eye doctors working with school health resources like yourselves and working in the educational process all need to come together to help to solve the problem. That's all I have to say in the beginning. I'd like to thank everyone, and we'll now turn the next segment over to Dr. Stacy Lyons. Thank you.
Thank you so much, Dr. Moore. And thank you again, everyone, for participating in today's webinar. We do have another poll question for you. Our next poll question is, do you participate in school-wide screening programs? Please answer yes or no. And I'll give everyone a few seconds. Couple more seconds. Okay, so 53% of you said yes, that you participate in a school-wide screening program. Thank you, everyone, for your participation in this poll question. Now I will pass the control over to Dr. Lyons. Dr. Lyons?
Yep, can you see my slides? Oh, there we go. No. I'm not getting the... There we go. Perfect. Do you have it now?
All right. Yes, we do. Thank you.
Perfect. Thank you, everyone, and thank you to the School-Based Health Alliance for holding this webinar and for allowing me to participate. Just to reiterate a little bit about what Bruce had just said, we know that as Bruce went through those vision disorders in young children, it is the fourth most common disability in the United States. However, what's really interesting to me about children is that they don't know how they really should see. How they see is what is normal to them. Because of this, children rarely complain of vision issues. And for the most part, vision problems don't hurt. Vision screenings are made up of a few tests that identify children who are most at risk to have potential vision problems. It's not diagnostic. A good vision screening is one that is labor-intensive, as 53% of you know, but with early detection and treatment can improve the outcome for most vision problems in children. Screening is for conditions for which the benefit of early detection outweighs the harm. Detection and treatment is best during pre-symptomatic or early symptomatic periods. For children, if a child already has symptoms, then they should bypass screening and be referred for comprehensive care. When I look at this slide, I look at a vision care continuum. And vision screening is often the entry point into this vision care continuum. So vision program involves a complete spectrum of care, and this includes screening, comprehensive care, treatment, which may be, as Bruce said, eyeglasses or patching, lots of education, and then plan and support that requires good communication with the network of advocates that a child has in order for the treatment to be more successful. For example, the eye doctor must communicate with the school nurses, who then would communicate with the educational professionals. This may consist of the teachers, the speech therapists, the OTs, the PTs, so the school community can support the child in properly wearing their eyeglasses. This is an integral piece in ensuring compliance, which brings us to ongoing care and then back into the continuum. And I'm going to come back to this in just a few minutes. A comprehensive eye exam diagnoses the problem. It diagnoses disorders and diseases and prescribes treatment. It's performed by an optometrist or ophthalmologist and evaluates refractive state, ocular health, assessment of eye movements, alignment, and color vision. If I think about who should have a comprehensive eye exam, and this question comes to me all the time. Well, any child who fails vision screening, and that's whether with the pediatrician, nurse practitioners, or at school, should have a comprehensive eye exam. Also, because screening is to detect children who may potentially have a vision problem, children who already have some signs or symptoms also should bypass screening and go right to comprehensive care. So if there's displays of any signs of a vision problem, if there are any concerns about reaching developmental milestones, if there are concerns about a child's reading, learning, or performance at school, they should really bypass the screening and go right to comprehensive care because there's an increased risk of potential vision problems. Included in this, if a child has a systemic condition which is associated with eye sequelae, such as diabetes or juvenile rheumatoid arthritis, those children too should go right to a comprehensive care. Since children congregate at school all day long, you are the essential part of having first-hand information about knowledge about this information. And that's why it's essential that schools be part of this process. Coming back to this vision care continuum, and I look at this diagram, we have these arrows that are in place. And these arrows represent potential gaps in the continuum. And it's important for all of us to work together to work towards closing these potential gaps. In looking at some studies of reasons why follow-up eye exams do not occur, let's think about those gaps for a second and think about those gaps in time. And there's lots of studies that look at the amount of time from failed vision screening to comprehensive eye care. And this has been repeated in a number of studies, and it appears to be about 18 months. 18 months, it seems incredibly long, and that encompasses, it could encompass as much as 2 school years. In another study, 40 to 65% of children did not access an eye exam after failed vision screening at all. And this gap was larger for children of ethnic minorities. So what are those barriers to care and treatment? Well, lots of studies have looked at this, and they look at the first one is knowledge. What is the knowledge of screening versus comprehensive care and that potential impact of vision problems with learning? Are they aware? Is there knowledge about the awareness of resources that are available to them? Or the lack of knowledge of where to go for an eye exam? Or this difficulty in navigating this healthcare system? Questions that my patients always talk to me about, you know, do you take my insurance and what does it cover? Are eyeglasses cover? If not, what do they cost? Hours that are convenient in the schedule? And is your office easily accessible by public transportation. And in the clinic that I work in, language and culture have a very strong component. Do you speak my language? Where I practice, 31 languages are spoken in that community. And is there someone who could potentially translate for me? And the barrier that really should have little gold signs around it should be trust. And that's trust in screening results, in the healthcare system, in the provider. It's important to explore the reason for your individual community for potential noncompliance and understanding that the barriers that develop need to be solved by community-based solutions and increase that compliance to follow-up exam and to treatment. When I look at increasing compliance with follow-up exams, I look at what information I need to provide to the community. I think about the solutions and try to remove some of the barriers. I need to provide materials. Materials, some I developed myself, and some we've acquired from other sources. This information often takes some time to gather. Face-to-face meetings are always the best way to convey this information so a conversation can occur and questions can be answered. And Rhonda is going to be talking about some of these resources in just a bit. Along with increasing compliance with the community. You need to be familiar with the community resources, how to build partnerships with these providers, and explore potential options in service delivery. At the New England College of Optometry, New England Eye Institute, which is the clinical arm of the New England College of Optometry, we've been working on this quite a bit. And we've been striving to optimize learning. And what we did was New England Eye Institute, the Framingham School-Based Vision Center was established in 2005. And it was a collaboration between the Framingham Public Schools and the New England College of Optometry. And this school-based eye center offers access to all children. We accept most insurances, and through the Affordable Eye Care Program, no child will be turned away for inability to pay. Eyeglasses, if covered by their insurance, we get them through their insurance. If a child cannot afford eyeglasses, we have the ability to cover that as well. At the center, we have about 1,000 square feet and 2 fully equipped eye exam lanes to do comprehensive vision examinations. As I said, we provide eyeglasses, we provide vision therapy, and contact lenses. Framingham is a community about 25 miles west of Boston, and as I said, we have 31 languages spoken in the schools and have a patient care coordinator who speaks 3 languages, the most common, Spanish, Portuguese, and English, and have translators potentially for the other languages that come into our office. The New England College of Optometry, New England Eye Institute, also instituted the OnSite mobile clinic. And the New England College of Optometry actually started working with the Boston Public Schools, helping to provide vision screening in the late 80s. On October 14th, 2010, which just happened to be World Sight Day, we rolled out the OnSite mobile clinic, and it delivers comprehensive vision care at schools in Boston as well as surrounding towns. Again, the OnSite mobile van offers access to all children. We accept most children, and through its Affordable Eye Care Program, no child will be turned away for the inability to pay. Eyeglasses are provided as well, and they're delivered back to the child's school once the glasses are fabricated. We don't have the ability to fabricate on the van, but once they are fabricated, they get brought back to the school and fit to the child. Another program that we worked on was to work on that area of plan and support. So now the child has glasses. They've been examined, they have glasses, and now we have a program in place called Eyes That Thrive. And Dr. Catherine Johnson of the New England College of Optometry was the project director, and Kathy Mazuk, the Northeast Regional Director for Prevent Blindness America, Corinne Metaroja, who at the time was the ABCD Head Start Health Service Director, and myself developed and implemented this community-based program to support school-based care of prescribed treatment plans for children with vision conditions. However, this program could not have been developed or implemented without the collaboration and energy of the Head Start community. And this was a grant from the 2011 Healthy Eyes, Healthy People State Association grant from Massachusetts. The project components consisted of a vision action plan. It consisted of 2 pairs of glasses, just as Bruce was talking about, one that was kept at school and one that was kept at home. It consisted of individual education cards, lots of education for Head Start health managers, staff, and family, consultation available to Head Start health managers, family, and staff, as well as a compliance tracker that we were able to use for evaluation. The individual education cards were condition-specific education cards. It was kind of like the child got diagnosed, we were able to hand out a card, and they were developed and they were distributed not only to parents, but teachers and health managers of all children enrolled in ABCD Boston Head Start with diagnosed vision conditions, and they were available in English, Spanish, Chinese, and Haitian Creole. The reason they were in those languages, those were the languages that were spoken in the pilot sites where we ran this particular study. On the back of all these cards were what we call the frequently asked questions. What happens if my child breaks their glasses? What do I do? Where do I go? So it solves some of the questions that we get every day. The Vision Action Plan, all students or all children enrolled in ABCD Head Start with diagnosed vision conditions had a Vision Action Plan completed for them, and it was signed by the parent, the health manager, and the eye doctor. The Vision Action Plan included information regarding the diagnosis for that particular child, the treatment plan, and the follow-up plan. And it became part of a child's individual health plan or health record. The individual health plan was already established method for documenting and supporting action plans for health conditions such as asthma and diabetes. And this was supported by the case manager who was assigned to each family in the Head Start. Previously, the individual health plan didn't include any information about vision. The results of this particular study, as I said, what we did was we had a compliance tracker. And the compliance tracker was hung up in each classroom where a child who was diagnosed with a vision plan. And the teacher every day would mark, was the child wearing their glasses? And it actually became part of the curriculum. Books were read on Arthur's eyes and to support the child who was wearing their glasses. Many teachers even wore their glasses to show that it was okay to wear glasses, I wear them too. The results of this particular study, looking at compliance with the Vision Action Plan, was that 93% of the total days children were wearing their glasses at school. Many health managers actually changed glasses as they came in during the day. They went to the health manager who put their school glasses on. At the end of the day, they switched to their home glasses. This program has been now replicated through Prevent Blindness America in the states of Georgia and Ohio. When we look at these things and we look at increasing access through different programs like the School-Based Vision Center, or we look at the mobile vision van, including with the Eyes That Thrive program, we look and say, what is the impact? And this particular study, looking at impact and looking at integrated vision health interventions on follow-up care for children who failed vision screening and Head Start programs. And the research was presented in 2013 at the American Public Health Association's annual meeting. And what they looked at, the aim of the study was to evaluate that impact of integrated vision health interventions on follow-up care for children who failed Head Start screening. They looked at data from 2 years, and it was to evaluate follow-up for children who failed that vision screening. In 2007 to 2008, this was before the OnSite van rolled out and the Eyes That Thrive program was implemented. 2011, 2012 was after these programs were instituted. All the children enrolled in Head Start had vision screening within the 45 days of entry, and that's a federal mandate for Head Start. In 2007 to 2008, 572 children failed vision screening and were referred for follow-up care. When we looked at how many children received comprehensive eye exams in timely manner, 14% received, only 14% received eye exams in a timely manner. In 2011, 2012, 419 children failed vision screening, and 100% of them received eye examinations and treatment. The conclusion, we need to work together. Increased access to eye examinations and treatment, increased parent and staff awareness of pediatric vision issues, and to develop community-based solutions that result in timely follow-up care for all referred children. We need to come up with very creative ways. And thank you for allowing me to participate.
Thank you so much, Dr. Lyons. And we thank you again, everyone. We actually have another poll question we would like to launch. What are your biggest obstacles in your vision screening program? Please take a few moments to answer this question. A few more seconds. Thank you, everyone. We have 63% lack of follow-up, the biggest obstacle in vision program. Now we would like to have our next presenter, Rhonda Schramm.
Hello, everyone. Again, I'd like to just thank you for attending this. This is the actual first time vision care has been taught on School-Based Health Alliance, and I'm extremely excited to be partnered with Dr. Lyons and Dr. Moore to help bring this to you. So just thinking about your poll questions and looking at it, those percents are not surprising to us, and that's what OnSite's trying to create access and resources for you. So I'm going to tell you a little bit about OnSite, and then I'm going to go in, of course, we're one of hundreds of ways that you can get support, but I'd like to talk about OnSite and what we offer. So OnSite's an independent nonprofit committed to eradicating the global vision care crisis. In the 27 years we've been around, we've helped about 9 million people in 40-plus countries to be able to see clearly, providing quality eyewear and comprehensive vision care. OnSite provides charitable and sustainable solutions for long-term care needs. What's our solution? So we want to provide, in a global effort, permanent access to vision care. So we believe that a sustainable infrastructure is going to be essential to empowering communities for long-term success. So we work with the government, with health departments, school districts, ophthalmologic partners, equipment vendors to support this. And we do it in several different ways. We do it in a charitable version that could be a 1 to 2 week clinic where we will come into your area with a van, with equipment, and bring in teams of optometric partners and opticians to do this. We also are going to be relaunching a voucher program that will provide, especially in very urban areas, large access to providers that will give comprehensive eye exams and glasses. And then, of course, something that's near and dear to my heart, which is the Sustainable Vision Center program that's actually located inside a school health center. We're able to support that with a central manufacturing and supply chain effort. So we have labs that will help to make the eyewear to be able to demand the demands from the clinics. So the resources that we have with the charitable vision clinic, what the qualifications for that is, so you guys can kind of think about when you do your school screening program and how many students you have that have a need. Qualifications for a charitable vision clinic for OnSite would be that you do have a school vision program, that you can identify up to 600 to 2,000 children that have failed, that have no financial needs, so they don't have insurance, or they have children's health insurance plan, or they're undocumented children. And the other item that you would have to be responsible for is making sure that you could get health consent and permission to treat the children. The OnSite resources for the voucher program is very similar. We'd hope that you would have the annual school vision screening program, and that you would be able to implement kind of like that, the gap in the plan that Stacy showed you with the arrows, that someone in your school system, whether it be the school nurse or a resource coordinator, can help to refer those children and families into, there will be a website portal that you can go to find the nearest local provider, and then also maybe help with public transit to, you know, I don't know if you can provide bus tickets or whatever, but that will also help to connect that. And again, for the voucher program, you know, if they don't have any financial needs, so if they have no insurance or CHIP insurance or an undocumented, those are people that we would like to be referred. And I'm sure you're probably wondering, when we talk about children's health insurance, you're thinking, why would we see those? And so there is some limitations to what providers, the access to those providers. And what I mean by that is that the reimbursement rate sometimes is not very high for a child that's on health insurance plans. So we find that while doctors will schedule appointments for those children, they may be very, very limited. So they may only have a couple a week that'll be availability because they would have so many self-paid insurances. So then we find ourselves, these children have to be booked way out in advance to be able to get the eye examination and glasses. So if you think about what Dr. Moore said and Dr. Lyons, you know, there are some times that we need to immediately get children to be seen, and if we have to book them several weeks out for exams, then they fall through the gaps and they don't get what they need. So then the Sustainable Vision Center, the qualifications for that would be, so that's a permanent vision center that would be inside of school health. Again, we would hope that you would have a school vision screening program in place. We would hope that the school district would have around 20 to 30,000 kids. So we don't just build vision centers in every school health center. There is a financial model that goes with it, and there is a certain kind of recipe that you need in order for that to be able to sustain itself through the CHIP insurance. We'd also, the other thing is that when you look at where the school base is, we rely on busing kids from other schools into it, so that there would be a need for the school district to help support with some type of transportation, and then space. So if you have a school health center already in your school and you want to add services such as vision, we can start around, I mean, we could go as low as 600, but when you're bringing kids from other areas in, you really want to start from 8 to 1,800, and because you're going to need that area of space to accommodate it. And again, in the School-Based Vision Center, we see everyone. So the children that have Children's Health Insurance Plan or CHIP, we would let the Vision Center would submit for reimbursement, and those monies would go back into the Vision Center to help support it. And then the children who are uninsured, those children would then become part of OnSite, and through the OnSite sponsor, we would provide the eyewear for those children. So again, no child would go without. So that's pretty much about OnSite and the 3 types of model we have. And I would pay attention closely to School-Based Health Alliance's web-based website, because we will be providing more and more access to those 3 types of programs that you'll have. The next couple pages are really about vision care resources and who can help you. So I'm going to go through these, but these will be on the line so that you'll have them. But these are great partners. You want to always look for your national and state optometric partners. So if you go to the AOA to look that up, they have, their webpage is very easy to navigate through. You can even navigate through to your individual state. And what that'll do is that'll open up the window to providers. We're talking about optometrists and just optometrists through this website. There's also an ophthalmology website that's down at the bottom, but that will open up the network for you so that you'll know the folks nearest you that you can refer your children to. Prevent Blindness is a fantastic website. They have a lot of resources on their website, from screening programs to screening. They have screening tools that you can purchase. They have webinars they do. They also talk about your state regulations. There are states that have regulations for vision screening programs, and they also have a link to nonprofits, so you can look in your state, and they can also help support you to be able to close that gap. Because remember, vision screening is just an identifier. The most important thing is getting that child to a comprehensive exam and glasses, and Prevent Blindness is an avenue or a highway to help deliver that. Another good site is the Associations of Schools and Colleges of Optometry. They have a lot of different, just like New England College of Optometry has, a nonprofit arm. They can also help you to drive, children for help for comprehensive exams and glasses. And again, the ophthalmology wing, and that would be really important, especially if we find medical conditions that the children should have. Some nonprofits associations that we have, which is again the AOA. We also have VSP Global, which is something similar to what OnSite is. They kind of do a similar thing with a voucher program. They actually have a website that you guys can log on to. You can look in your area, and you can log. You can also find the providers that are local to you, and you can help set up appointments for those children. And they do kind of have a similar criteria that we have at OnSite. Eckler Foundation is the same. They have Kids Vision for Life. They're mostly on the West Coast, but they also offer the same similar functions. Prevent Blindness, I went ahead and put their website and a telephone number. This is kind of like their resources, so this will walk you through how you can get an eye exam and glasses for your child. So that's a great resource that you can go back and look at. I'm going a little quick because I want to leave time for you guys to be able to ask questions in the end. Site for Students is another resource. There's the website. You can go there. They'll help you. They have an easy navigational process. Put your zip code in, and it'll also give you resources for eye exam and glasses. And then I just want to talk really quick about School-Based Health Alliance and our partnership. So in 2016, 2016 is just around the corner, and you'll notice as you're a member that there will be a Vision Services Blueprint, and that Vision Services Blueprint will have resources about OnSite's voucher program, about charitable clinics. It's also going to talk about the OnSite Vision Center sponsorship and the school-based model itself. Along with that, it'll also have support pages for other partners that are out in the United States that can resource you. So I hope that you'll take the opportunity to check back in 2016 for that coming soon. It's pretty exciting. And there's our website. If you would like to go to that, there's a tremendous video out there that shows you how the Euler School operates and tells the whole story. It's very touching, and I hope that you guys will go to the website and check it on out. So thank you so much for your time.
Thank you so much, Rhonda, Dr. Lyons, and Dr. Moore. We really appreciate you guys coming on and having this great information for our webinar today. We are at the top of the hour as far as the webinar, but we do just want to go over a few things. And for anything we're not able to get to, especially anyone's questions, please submit them now if you have any questions. The questions we may not be able to get to, but we're going to try to maybe get to maybe one. For those that we do not get to, we will definitely send those via email. We'll send them to our presenters so they can get back to you. So we just want to thank everyone for attending today's webinar. We also want to talk about our membership. Like Rhonda was saying for the Blueprint, if you would like any access as far as the Blueprint or more information about School-Based Health Alliance, please become a member. It's great benefits that we have for our membership. It is $100 for individual and $500 for organizational. Once again, please answer any questions that you may have. We'd like to thank everyone today. We do have a couple of poll questions we'd like for everyone to answer. If you can, just take a couple of seconds. The first question is, did this presentation meet your needs today? If you can please answer yes or no, just take a couple of seconds. Thank you, everyone. We appreciate your input. We have another poll question. How well did this presentation meet the stated objectives? If you can please enter your response in just a couple of seconds. Thank you very much, everyone. Our next poll question is, how likely are you to apply this information? All right, we just take a couple of seconds. All right, thank you very much. And we just have our last poll question here. Would you recommend this webinar to others? If you can just take a couple of seconds. Thank you very much, everyone. We will ask one question for the presenters. What is current cutoff for critical period? And I believe this might be addressed to you, Dr. Moore.
Can you hear me?
Yes, I can.
Okay. That's a tough question, and it's one that actually is the basis for a whole lot of research that's going on today. We now know for certain that this mythical 7-year old cutoff is not true. We actually are able, in some cases, to treat amblyopes even in their teens and 20s, and there's some very cutting-edge research going on now that we're involved in that has shown we can resolve amblyopia in individuals that age. There isn't much question that neuroplasticity has a gradual decrease probably throughout the teens into the 20s. But it turns out that the real question is less the plasticity issue or neuroplasticity more specifically than it is compliance with treatment. It's a lot easier to get a 3 or 4-year-old child to wear glasses and use a patch than it is a teenager for all the obvious reasons. So I think we're going to learn over time that this issue of critical period and neuroplasticity is not as critical as it was before. And as we're beginning to learn some of the underpinnings of the neuroplasticity, I suspect that there will be many fewer barriers to treatment at a later age than we thought in the past and think today. So I hope that answers the question.
Thank you very much. We're going to try to put in one more question before we close. The last one is, what is the best method to screen a child with glasses when we do near vision screening at school?
I guess I'll take that. Probably through the glasses. The glasses were prescribed, presumably by an eye doctor, to meet the needs of a child in a variety of settings, but in particular the school setting. So if you're going to be doing either distance or near visual acuity testing, I would say definitely do it with the glasses on.
Thank you so much. We appreciate everyone for attending today's webinar, including our presenters for this amazing information. If you have any other questions that you would like to send, please do at info@SBH for all. This webinar has been recorded and will be uploaded to our website, including our slides in 3 to 5 business days. We thank you, everyone, and have a wonderful day.